Hi, everyone. I'm Dr. Steve Phillips, and I am trying to connect the video. And here we go. I'm going live on Facebook as well. Hi, everyone. I'm Dr. Stephen Phillips. Thanks for joining me tonight. I'm going to be talking about long COVID. And as many of you may know, when I and my co-author Dana Parrish had written a book called Chronic about the chronic illness manifestations of a pandemic of infectious disease, meaning vector-borne infections and some others, the world exploded with a pandemic of infection, namely COVID, that ended up causing a pandemic within a pandemic, which turned out to be long COVID. So we postponed the debut of the book, the publishing of the book, and furiously researched COVID, added a chapter, researched as many COVID quote-unquote experts that we could find, about 20. Who's an expert when there's an infection that's basically the world has known about for 2 months? But within that span of time, long COVID started to shape itself as an entity, and there popped up a few long COVID clinics around the country. So I was tasked with interviewing a doctor who headed up one of those clinics at a major academic center. And she told me that she thought that long COVID was a psychiatric illness, that there was nothing wrong with these people. And that's it. And I remember thinking to myself, what arrogance in this person. And we ended up not including her interview in the book. But I remember I asked her, what if you're wrong? I mean, it's only been out for a couple months. What if you really are wrong? And she said, I'm not. So now that we know a little more, in 2020 hindsight, I can tell you that long COVID is quite common. Today I'll be presenting a variation of a PowerPoint presentation that I gave at MIT, and with a little extra context as we go along, because I don't know, about a year ago, we started opening up the practice of long COVID patients. At the beginning, I abjectly refused to see a long COVID patient. I said, what do we know about long COVID? And then, it was pointed out when I spoke a couple of weeks ago about MS, why is the symptom list for chronic Lyme nearly identical to the symptom list of long COVID? And obviously it started to dawn on me. So without further ado, I'll add a little PowerPoint presentation here, and let's just follow along. So again, thanks for joining, and here we go. So what's very, very plain, and I'm going to just minimize myself here so I can see the screen. What's very obvious to everyone is that long COVID is common, that at 3 to 6 months, 2/3 of patients have persistent symptoms. At first, it was very plain also that hospitalized patients, people with more severe illness, had a higher rate of long COVID. But then it became kind of curious that even people with mild illness were developing long COVID, and it wasn't proportionate necessarily just to the degree of illness that they had. And at 6 to 9 months, about a quarter, almost 30% of people have persistent symptoms. So they try to define long COVID as autoimmune, post-viral, post-infectious. It's a very, very dangerous path, because this is what they tried to do with persistent symptoms related to Lyme. Chronic Lyme has been described as post-treatment Lyme disease syndrome and post-Lyme and everything under the sun. And it's very damaging, because these words, they guide care. If you are perceived as not having an infection anymore, then you're treated very, very differently than if you have a chronic infection. In the case of Lyme, there's robust literature that I present on a regular basis that shows that the bacteria that causes Lyme disease persists in people despite really long-term antibiotics. And to take it a step further, they have something called post-Ebola syndrome. And why they haven't changed the name of post-Ebola syndrome, I have no idea. So the prevalence of post-Ebola syndrome is very common. It's about 90% of people have this constellation of symptoms. And the issue is that they find Ebola viral RNA in the semen and breast milk and saliva and urine of patients with post-Ebola syndrome. And in the semen, it's the most common, about 10% of samples. And there was even a little mini epidemic related to a gentleman who spread Ebola, and he was described as having post-Ebola syndrome, and they started a little epidemic. So we clearly think about viruses in the way that We think about everything. We think of them as black and white, and there really are these shades of gray. So just to think of things that are viral infections that are known to be chronic, like HIV and herpes, and viral infections that we think are fleeting, like hepatitis A, it doesn't really work that way. Even the common cold, this is data from 1973. There were 12 men that were spending the winter in Antarctica. And after they were there for about 17 weeks in complete isolation, which is way outside the incubation period for the common cold, just one by one, 6 out of the 12 came down with symptoms of the common cold, indicating that we don't even understand the nature of how regular seasonal coronaviruses work. And even before COVID came along, there was all this data that coronaviruses can set up chronic infection within cells, in the brain, inside cells elsewhere in the body. And even with influenza A, there's been data that they've found infectious virus from the tonsils of asymptomatic children who could then go on to spread the virus. So in terms of long COVID with persistent viral infection, they have found that about 3 months after recovery, about 5% of the people will test PCR positive by nasopharyngeal swabs. And they make a point to say that these people are not contagious. And they also found that even many days after recovery, patients can be found to harbor DNA of the virus in their GI tracts, and the nasal swabs are negative at that point. But there is such a thing as relapsing illness with COVID as well. Some patients have relapsed after initiation of immunosuppressive therapy. Some patients, they've found viral DNA up to 6 months after the acute infectious period has passed, and they found it in their olfactory tissues, way past where a swab would typically go, way up into the olfactory bulb. There's even this well-known case of a relatively young man who's on immunosuppressants, and he had relapsing COVID many, many times. It came and went, and it finally killed him. So we have been turned into an immunosuppressed community. I would say most of the commercials for drugs that I see on television are immune suppressants, probably followed by erectile dysfunction drugs. So it's an explosion of immunosuppression that's basically man-made. So this is the symptom list that was brought to my attention when I was speaking about MS, which is a very real and accurate observation, that the symptom list of chronic Lyme, symptom list of long COVID, and the symptom list of ME/CFS, so myalgic encephalitis, chronic fatigue syndrome, overlap in a remarkable way. Now, why is that? So researchers, when they look at ME/CFS, they say, look, this is probably an infection, and there's probably multiple infections that can cause, trigger, whatever terminology you want to use, ME/CFS. And among them include many viruses, and also Lyme and Coxiella, which is the cause of Q fever. So what happens if people have asymptomatic infection and they get their immune system disrupted by a virus such as COVID? People don't realize how common asymptomatic infection is with Lyme and Bartonella. So what's Lyme? Well, Lyme technically is caused by a spirochete called Borrelia burgdorferi, and it's nicknamed the Great Imitator because it can cause this very large spectrum of illness. But it's really not just Lyme bacteria. It's a family of organisms, including Lyme, but other things as well. And overlapping spectrums of illness exist for Bartonella, Brucella, Coxiella, and other organisms. And the common feature of these bacteria is that they're very, very difficult to isolate from people who have these infections. So before going on with just a PowerPoint, because I know last time that PowerPoints, I think, can get boring, I want to exit out of the full screen and maybe just take a few questions if anybody has questions as we go along, because I don't mind interrupting this and doing it in a more informal way. So I'll just scroll through here, and I see some familiar names. Hi, everybody. Hi, Jonathan. So I don't see any questions here, so I guess I'll continue as we go along then. So what I mentioned before is that COVID immune dysregulates. What does that mean? It means it immune suppresses and it causes inflammation of the worst parts of the immune system. This is a study where they looked at different infections and said, are all infectious diseases, are all diseases infectious? Meaning that diseases that were typically not thought of infectious nature really were found to be infectious. Things like H. pylori causing ulcers is the perfect example, but there's many others. And with COVID, they're finding that there's a very large increase in autoimmune diseases after getting acute COVID. Why is that? So we find that Lyme can cause autoimmune conditions as well. Things like Sjogren's, sarcoidosis, small fiber neuropathy, and adult onset Still's, which is basically juvenile rheumatoid arthritis in an adult version. And then also there's more serious conditions related to Bartonella, things like sarcoidosis, erythema nodosum, and Wegener's. And these conditions can be treated by antibiotics. Is that just a coincidence or is that a real finding? So it goes on and on. I've unfortunately had many of these conditions. I've had uveitis, I've had autoimmune hemolytic anemia and autoimmune thyroiditis, as well as seronegative spondyloarthropathy and seronegative arthropathy, meaning arthritis. And here we have Bartonella causing and mimicking juvenile rheumatoid arthritis. Have they done antibiotic trials for juvenile rheumatoid arthritis? The answer is no, they haven't. But they have done quite a few antibiotic trials for adult rheumatoid arthritis, and the studies are clear. Antibiotics work, and the placebos don't. And what about new onset psychiatric illness after COVID? They're finding that this is actually a very common thing. It's happening to a friend of mine's son right now, and it's really tragic and horrible to witness. And with Lyme, they found that psychiatric illness is common, that it's almost twice as common in people with positive Lyme tests versus negative Lyme tests, and that people that have cat scratches and bites, which are well-known risks for Bartonella, have higher rates of depression. So these are some of the psychiatric features seen with Lyme, things like bipolar, anxiety, depression, OCD, and schizophrenia. And they're finding that depression is common with late Lyme disease, and it can be responsive to antibiotic therapy, especially when it fails normal antidepressants and things like those. They've even found psychosis related to Lyme and Bartonella. And again, a common theme, not responding to regular antipsychotic medications, responding to antibiotics. And again, I'll exit out of the full screen, see if anybody has any questions. And don't see any yet. So here I just want to include a case report of a couple of patients that I've seen that did come to see me with long COVID. And the first is a man who got COVID in the first wave, and soon after he developed POTS, which is postural orthostatic tachycardic syndrome. And it's when people can't get control of their heart rate and pulse. And of note is D-dimer, which is a measure of actually clot dissolution. So therefore, it's an indirect measure of clotting was negative. And you know, COVID can be a clotting disease, obviously. And his case was noteworthy because his D-dimer was normal. And I bring that up because we'll see what helped him later on as I present. So he had a presentation of severe headaches, which got worse when he tried to concentrate. His spinal tap showed white blood cells, which means inflammation, but no diagnosis was made, and he was given no treatment. He was referred to a long COVID clinic, and they in turn referred him to a psychiatrist, but he didn't have a psychiatric problem. His Lyme Western blot turned out to be positive, at one lab at least, and he was not given treatment at that time. So instead, he was given Meroverac, which is a medicine that's commonly used for things like HIV, and statins, which are cholesterol drugs, fluvoxamine, the antidepressant, which has some activity against COVID, and ivermectin. And they really didn't help. And then he was treated with doxycycline, and that didn't help either. And then he was scheduled to go for an orthopedic surgery that was not related, and they gave him Eliquis, which is a blood thinner, around the time of his surgery, and he woke up for the first time without a headache. And then just before I saw him, I think it was like in August, or just after I saw him, he got COVID. And another doctor treated him for COVID. And when he got COVID, despite the medicines that the doctor gave him, his headaches came back in full force. And typo, I see there. But despite doubling of the Eliquis. And the noteworthy feature here is that, unfortunately, MRI of his brain demonstrated multiple vascular lesions in the veins. And he had a finding that was compatible with a microhemorrhage. So he's really at a lot of high risk from these blood thinners. It was the only thing that was helping him, and he stayed on them. So he stayed on Eliquis despite the obvious risks, and he saw me. And given that doxy didn't help, a lot of people don't respond to doxycycline. So I gave him tetracycline, and he improved. He had small Herxheimer's that were really easy to miss, and it took a couple of pulses to be sure that it was really helping. And for those of you who know how I treat, a lot of times I'll do intermittent courses of therapy because I feel like they can work better for a lot of folks. And his headaches, and these, to say that they were just headaches is not to really do them justice, because to motivate him to take Eliquis despite his overt risks, despite the vascular malformations, it means that his headaches were very, very severe. So whenever he tried to use his concentration powers for anything, he would get debilitating headaches. But after 2 months of tetracycline, which took about 4 months due to the pulse nature, his headaches resolved, the stiff neck was gone, the muscle pains went away, joint pains of his right knee and his sacroiliac went away, and his blurred vision went away. And he was able to wean off the Eliquis. And I don't know if he's fully off it now, if he's still in the weaning process, but he's done quite well, and we'll see. And this is just the beginning of this treatment with me. I don't know where it'll take him, but tetracycline is certainly not the end-all be-all of treating vector-borne infections. He still had right hip pain and right shoulder pain, but he's an extremely athletic guy. And like I said, he had these pre-existing orthopedic problems, and then maybe some unrelated orthopedic stuff that's not, due to vector-borne stuff. So case number 2 is a 42-year-old guy who in his 30s developed burning abnormal sensations around his spine and fatigue, feeling sick, right-sided droopy eye, double vision, and joint pain. He was seen by an ophthalmologist, given prism glasses, seen by a neurologist, and the workup was negative and he wasn't given anything and he didn't know what to do. So he went on a keto diet on his own. He felt a lot better. And he remained well until November 2020. He came back from Mexico with some type of infection. He's not really sure what, and I'm not sure what it was either. But the diarrhea lasted like 6 months, and he developed atrial fibrillation about once a week for a few hours, and then chronic fatigue and feeling sick all the time and thirst. And the keto diet was not helping. From 2021 to 2022, he was diagnosed with long COVID. He was treated with short courses of multiple drugs that didn't help. He was on Marovirac, aspirin, Plavix, steroids, and ivermectin, and didn't do much. The only thing that helped him at all was mast cell stabilizers, things like antihistamines and some supplements that are also mast cell stabilizers, like quercetin is a mast cell stabilizer that's a supplement. And he saw me also in August, and his Bartonella antibody was positive, and his Lyme Western blot had 3 bands. So he didn't meet the CDC criteria for Lyme, but per CDC, 90% of patients that have Lyme fail to meet their criteria or fail to get captured by their criteria. So you say, what kind of criteria is it where 90% of cases don't meet that criteria? So looking back at what happened to him when he was in his 30s, and he had this multi-system illness of unknown etiology, it kind of all makes sense through 2020 hindsight. And then he got this illness in Mexico, and his immune system appears to have been destabilized, and then he had chronic illness after that. So I've just seen him twice, and this is his list of symptoms, and they're all really a lot better, except for a couple. And he did experience Herxheimer's on monolaurin, or well, let's put it this way. He experienced flares of his underlying symptoms or compatible with Herxheimer's when he started monolaurin, doxycycline, and then tetracycline. And this is the sum total of what he's been treated with. It's really 3 weeks of doxycycline and 2 weeks tetracycline thus far. And I'm going to be treating him, with additional meds. But I guess the point of bringing his case to your attention is that he suffered very severely for a long period of time. And it's not just that his regular heart palpitations improved with antibiotics, his atrial fibrillation, which a lot of people think cannot be related or, is a matter of old age or this and that. I mean, obviously this is not an old man. And his atrial fibrillation improved with antibiotics. So that's going to be it for the PowerPoint presentation. But my impression is, and like I said, the reason we didn't take long COVID patients at the beginning of the illness, because I didn't feel like I knew enough. I touched upon last time that I got COVID early on in January 2020, and I have definitely declined physically since then. And I still was not smart enough to put everything together until I had a patient who had a case of Bartonella, and her case of Bartonella exploded after getting COVID. And then she did respond to medications. I was like, wow, people are thinking she's got long COVID. It's responded to antibiotics. Maybe we should accept some long COVID patients. That's exactly what we did. And I would say thus far, they're responding the same as my average patients with vector-borne infection. Do we have some patients where they have a preponderance of clotting things? We have a few, but it's not to say that the clotting stuff is exclusive to the reactivated infectious part of the puzzle. So it appears that COVID causes long COVID in a couple ways. And one, in my opinion, is immune dysregulation with reactivation of prior infections, and the other is activation of clotting cascade. So in the case number one, when my patient responded so beautifully to Eliquis at first and got so much better, it's very tempting to think, oh, his the mechanism of his illness must have been microclotting because the Eliquis worked. I don't know. I don't think necessarily that's the case, to be honest. Not because the D-dimer was normal, because some people with microclots can have normal D-dimers. A lot don't, but some people can. It's because of how rapidly it worked for him. It doesn't really dissolve clots that well. It kind of like changes a steady state clotting dynamic. And then when I started researching it, I found this study of Eliquis having some limited antibacterial activity, just very focal. And then I found another study of this other anti-clotting drug, this other anticoagulant, also with the new ones, I think it was Pradaxa, has activity against Staph aureus, and people actually had lower rates of Staph aureus infections when they took Pradaxa. So I would just point out that a lot of drugs out there have antimicrobial activity that people would never trace back to the drugs. They don't think of them in terms of antibiotics. I mean, they're clearly not, but many things have antibiotic-like effects that are not antibiotics. A perfect example is fluconazole, which we use in the office quite a bit. Fluconazole was discovered by accident. There was a doctor in Germany who had chronic Lyme, and he did, I think it was like 4 years of antibiotics or something like this. And he ended up doing IV antibiotics, and he got a fungal infection from the IV antibiotics, and he took fluconazole, diflucan, for the fungal infection. His Lyme got better, and that's how that kind of got discovered. And then Johns Hopkins tested it in the test tube, and even though it's antifungal, it kills Lyme bacteria really strongly. So I wonder, could Eliquis have a dual effect? And to my knowledge, nobody has tested it. But the rapidity of his response to Eliquis it just spoke to me as being outside the scope of what I would expect if it was working on an anticoagulant basis. So I'd like to open it up to questions. And if anyone, I'll scroll back through here. If anyone has any, not that I am the oracle of all things long COVID, but I can share what I've seen. So here, Tony says that COVID vaccine sent my Bartonella off the chart. So when the vaccines first came out, as you know, as most people know, and the people who don't know, I'll just say it, doctors were not allowed to say anything except glowing things. And if you said anything apart from glowing things, you'd be kicked off whatever social media and threatened to get in trouble with different boards or whatever. But I always tell my patients the truth of what I see, and I don't pull my punches because, what's the point? So I think that There's some immune dysregulation that happens from these vaccines as well, and people should know about it. I've seen quite a lot of patients flare up after the vaccines, and I've seen a couple of cases of myocarditis. And the common feature of the myocarditis cases that I saw is that they were both completely ignored by their doctors. One is a woman, and they didn't know about myocarditis when she got sick, and she went into heart failure for about almost 2 years. And only in retrospect, you think, oh, it was probably myocarditis. But the other is a man, when it occurred with him, he's 50, and it happened well after we knew about myocarditis. And he was fine with the first 2 shots, and he got a booster, and he had crushing chest pain, and went to his doctor, and his doctor told him to sleep it off. And sometime later, he did some exercise, and then he went to the emergency room with crushing chest pain. They said, you're having a heart attack. And he told, I don't know how many doctors in a row that this happened right after the booster, and it wasn't actionable. Nobody would do anything about it. So his wife is an old patient that I treated a really long time ago. So she dragged him to see me to try and help. And I said, I'm shocked. Has nobody offered you a cardiac MRI? Because a cardiac MRI can help differentiate myocarditis from a heart attack. Because they ended up doing a catheterization. His coronary arteries were clear. So I got him into Yale on a cancellation as soon as possible, because the signs of myocarditis do fade. And sure enough, a radiologist called me. She's like, yeah, it's like myocarditis. So, and he thankfully recovered. So I'm sorry to hear that you went through that, Tony. Like I said, nothing is all good or all bad. People tend to kind of make everything black and white, and so here, another comment from Tony, Bartonella henselae. What was I saying here? So yeah, I mean, lichen in general, certainly lichen sclerosis atrophicaus has been linked to Lyme, and there's umpteen skin conditions linked to both Lyme and Bartonella. I had developed annuloma granulare, another autoimmune thing. So if I had to count up the number of autoimmune conditions that I could have had diagnoses for, it's kind of ridiculous. When someone has 6 different autoimmune conditions, you have to wonder what's going on, So as I scroll down here, this is just a comment from, so ME/CFS worse. Yeah, I agree. I'll show your comment. I agree. ME/CFS is a very neglected, and kind of people are put into this black box, and kind of, it's like, what is it? The millions missing kind of a thing. And that's, of course, I don't know how to use this program very well. Oh, but okay. Do you think these pharmaceuticals know there's 0 side effects? Do I think that these pharmaceutical companies know there's severe side effects? Are you talking about to the vaccines or to drugs in general? I mean, I think that large corporations behave as sociopaths. I've written about this in Zero Spin so many times. It's kind of a disturbing truth. It's been studied. So people do very bad things when they're in groups. I mean, history has taught us this lesson many, many times. So I think that some people know that certain drugs that are out there have bad side effects. So it was public knowledge, and they did exposés on it, that Merck had a list of doctors that they wanted to discredit when they were going through a scandal about one of their drugs. So, okay. So interested in steps for treating potential. Okay. So here, hi, Shirley. Interested in steps for treating potential long COVID shortly after acute stage of illness. So I think the first thing that I've done, like I said, when I looked at long COVID, I said, wait, could there be a vector-borne infection that's been reactivated here? I don't know, for people who joined later on, I was trying to get through the PowerPoint, that it's extremely, extremely common for people to have asymptomatic infection with Lyme and asymptomatic infection with Bartonella. It's the thing that nobody argues about in the whole field. Every aspect of the field is controversial except for that fact. But what happens to these people? what happens to them if their immune system gets disrupted by something, whether it's a medical intervention, a stressful event in their lives, COVID. I mean, before COVID came around, I would see people who were diagnosed with ME/CFS where it all started after a virus. And of course, it's very tempting, and maybe in some cases it's true to think that it's a purely viral etiology. But like with COVID and long COVID, is it just the virus that's there causing problems, or is it the virus's effect on the immune system and other infections that are there? It's all a big mess. It's like when they do studies of mice in labs. It's not real life. When they inject a mouse with Lyme, that's not how it is for the mouse when he's running through the field. So the mouse gets infected with Lyme and Bartonella and a bunch of other bacteria and a million parasites and viruses and everything else, and how they work together. So there's already studies in humans where in parts of the world where there's lots of parasites and lots of tuberculosis, it can really impact on the treatment of tuberculosis if people are dealing with parasitic infections because they're immune suppressive. So to think that COVID, which is so well published now to cause immune dysregulation, is not going to impact the other infections that people regularly carry, it's one of these things that no one seems to be talking about, but I feel it's important, so here it is. This is a good question. Can nicotine treat long COVID? I have not, there may be data I'm not aware of. There is data about nicotine preventing Parkinson's, interestingly enough, and I've been thinking about nicotine patches for a few of my Parkinson's patients, but I haven't done it yet. So, this gentleman, so I did. So, diagnosed with CFS 10 years ago. That's right in the summer. Okay, well, I'm sorry to hear. Here we go. This is it's a cutoff question. Why tied to the hot weather? Yeah. I mean, I'm not sure. I think it could be that there's just more stress on the body and such. I can tell you that my patients historically have always talked about getting worse in the fall. I thought that was tied to melatonin release as it's less sunlight. Because melatonin, actually, people think of it as just inducing sleep, but it also makes the immune system a bit stronger. And you think, oh, it's great to have a strong immune system. It is, but when you're dealing with infections like vector-borne stuff, the disease process is a very delicate dance between what the immune system does and what the infection does. Making the immune system stronger, you can get rid of more infection, but you can actually make the symptoms worse. And that's why it's got this ties to autoimmune stuff. So it's, when people take steroids, they can suppress symptoms temporarily, but it can make the situation worse in the long term. And it's kind of the opposite for things that make the immune system stronger. So when I treat patients, I look at not just the antimicrobial aspect of things, but there are a list of different immune modulators, things that can make the immune system work better. One of them is LDN, low-dose naltrexone. So that's not a very controversial topic. It's kind of widely accepted to work setting up a lot of autoimmune conditions, and the question is, how does it work? So it works by blocking endorphin receptors, and the body kind of thinks there's not enough endorphins and makes more. So it's like we make endorphins when we're happy and we're exercising. So we can think of LDN as happiness and exercise in the bottle. So, okay. So, there we go here. Here's the princess credit to. I'm trying to understand this question. I'm sorry, if you can post again, Daniel, just so I can understand the question a little bit better. And the audio distorted at the moment. Huh. Thank you for letting me know. So I could Okay, is that better now? Anyone? Audio distorted at the moment. Is the sound better? I don't know if the sound is working. What's that? Okay, so I hope I have the sound fixed. I don't know. I had so many technical problems last time with the formatting of the PowerPoint, and anyway, so sorry for technical problems, and very grateful to Owen Wilson. And okay, so hi Eileen. So is it really long COVID or is it reactivated infections, Lyme, Bartonella, Babesia, Epstein-Barr? I don't think it's an either or. The question is, what's long COVID? I think that like ME/CFS, which has already been shown to be like a heterogeneous group of disorders, long COVID may not be a single mechanism. I think that it varies based on the person. And like I said, we have some patients that have really clear evidence of clotting, and others that really don't have any evidence that we can find. I mean, it is really, really hard to find these microclots that have the amyloid in them. But even people, because I know that some of the researchers in the field, even people that are, when they're finding these microclots, which have a lot of amyloid, a lot of them have elevated D-dimers and elevated other regular clotting metrics as well. So I think it's a combination. I mean, it's weird. On the one hand, these people have, if they didn't get COVID, you would think that they're kind of destined not to be sick. So if they are reactivated infections, you would think they kind of have kind of wimpy infections, and maybe they would be easier to treat. Certainly in some cases, that is what I'm finding. I mean, the second case that I presented, I've only seen him twice, and he's gotten a lot better just with one round of treatment, basically 3 weeks of doxy and 2 weeks of tetras, 5 weeks of antibiotics, and the guy was suffering for a long time. So I don't know if there are any rules yet on how people respond, but I'd say in general, because does it sound still messed up, or I hope it's not messed up anymore. It has already killed over reactivated TB. If that's the case, that's a horrible statistic. Thanks for bringing that to my attention, Daniel. And I'm going to double check that. If you want to put something in the link, because that's a really compelling and miserable statistic, and that's something that's definitely, I think, tweetable and everything else. So thanks. If COVID has caused 1 million deaths with reactivated tuberculosis, it speaks to the level of immune dysregulation and what it can do for other people. So I'm going to definitely look into that. Thank you for bringing it to my attention. Which antibiotics would you recommend requesting from a GP for long COVID? I don't recommend anything on here, just talking about general topics and what I'm doing with my patients. But I've been, in this field almost 30 years. And there is no one best antibiotic for people with these infections. I had Lyme and then I got Bartonella, and my case is public because I wrote about it. And my case of Lyme was pretty moderate. My case of Bartonella was, by any estimation, absolutely miserable and life-threatening the whole bit. And my case of Lyme responded much better to tetracycline. My case of Bartonella responded much better to doxy, and really tetracycline does nothing for my Bartonella. So I think it's really individualized, not trying to be elusive at all. But in my practice, that's why, like with that patient number 2, we talk about doxycycline and then tetracycline. And there's a reason for it. We don't just do it for fun. We're trying to establish tetracycline class superiority. We want to know which of the tetracycline class antibiotics work best for each patient. Sometimes neither of them will work, and we have to go and use a different backbone of therapy. But you don't want to combine agents, and like always, I'll kind of analogize it to being lost and driving in the wrong direction faster and faster, for a long time. You want to just use your best team and not your second best team. So yeah, it does boil down to a little bit of trial and error, and nobody wants to hear that. People want to think that doctors have it all figured out. These infections, I would say we're like on chapter 2 of a really long book. And so when doctors make these statements about how things should be and what people should respond to, like I hear all the time that rifampin is the best treatment for Bartonella. I can't count how many times I've heard that. And I have some extraordinarily well-documented Bartonella patients, talking like positive biopsies showing Bartonella, not just by PCR, but also by direct pathology. I mean, stuff that is kind of proof positive that really Bartonella is causing infection, who did not respond well to rifampin. So, and responded well to things like Bactrim or something else. So I don't think there's a single best. I mean, I think there are groups of best in general. So can acyclovir treat reactivated Epstein-Barr or LDN, treat these things? Acyclovir doesn't work all that amazing for Epstein-Barr. And unfortunately, in terms of pharmaceutical antivirals, it's, more toxic ones work, which I'm not a fan of. I mean, I'm most a fan of, most people don't know anything about my love affair with monoleurin. I really do like monoleurin quite a bit. I have lots of patients on it. It has broad spectrum antiviral activity. I can tell you for sure, I've seen tons of patients who get chronic cold sores. When we put them on monoleurin, their cold sores stop. And the question is, though, it's not as easy to give proof positive if we're suppressing Epstein-Barr to the extent that we're suppressing cold sores, because with cold sores, you can see it, obviously. And my mic is static. I hope it's not anymore. I guess maybe we're going down now, no sound. I think it's, let me just double check one more time. Hello, hello. Yep. Okay. So it must be an old message. And there's my message saying, is the sound better? Okay. Okay. Hey, Happy. Okay. Thanks, everybody. Okay. And where COVID joined old viral fragment, Murdoch University studies finding. I'm not sure what that one is. I'm sorry. I'm just reading through here because the way the streaming service, use a streaming service to go to the different platforms, and all the messages get kind of jumbled from the different things like Facebook and Twitter and whatnot. So, but I think that the real thing that just the real point that I wanted to make with this video is that two things. One is that my initial observation, my initial interview of this academic doctor who was in charge of this long COVID clinic, I was, viscerally kind of wanted to express myself, but I didn't because I was trying to be polite and everything. But I immediately thought this is going to be chronic Lyme 2.0. And I hope that was wrong, but I'm not. It's turned out to be that way for a lot of long COVID patients. So the recurring theme that I've heard from many people, and I've had doctors come to see me with long COVID now at this point, and they're not getting any respect. The same thing that's happened with doctors who've come to see me in the past. I've treated over 100 physicians who've had chronic Lyme, is that everybody gave them, nice respect and everything else, all their peers, until they got sick with a mystery illness. And now the same exact thing is happening with long COVID. So people don't change, unfortunately. This is, I think it's like a civil rights movement almost. But the salient point is you have to start at a place of believing your patients. If you can't start there, then why are you a doctor? So that's the first point. But the second point that I really wanted to make about this video is that it seems like there are actionable items in evaluating long COVID patients. Again, I'm not saying it's all Lyme or Bartonella or these other chronic infections that we test for, but if 90+% of my patients are getting better, there's got to be the same elsewhere. And I just want everyone to kind of spread the word if they can, so people can get at least some hope that there's something out there that may help them. Okay, so Tony, I don't know what this refers to over here. This joint old viral fragment, Murdoch University studies finding. I'm not sure. If you could just clarify that, that would be great. And okay, everybody. Well, if no one has any other questions, I guess we can wrap this up kind of early. And I appreciate everybody tuning in. And And then let me just scroll through here, make sure that I didn't miss anyone's question here. Boop-a-doom. Tony says I make a great DJ. I don't think so. I don't think so. You know, technical problems with 2 videos, not great, but we do our best. So thank you, everybody, for your time and attention. Wishing you a nice evening. Okay, bye now.